Start, Michelle.
Just wanted to set the recording. So thank you so much for joining today. I'm very excited for this session. Personally, I had the pleasure of working with Dr. Adnan back in 2020 on the family planning project. So this is a session that I am looking forward to. Just for a little bit of introduction, my name is Michelle Kiani and I work as the manager programs and outreach at CADA Pakistan. And we are joined today by Dr. Adnan Khan, who is a public health researcher and policy expert. He currently works as the Chief Knowledge Officer at Research and Development Solutions, a Pakistani research group, as well as a member technical part-time to the Ministry of National Health Services, Regulations and Coordination. So thank you so much for joining us today, and we're looking forward to this session. So without any further delay, I will hand over the floor to you.
Thank you, Michelle. That's very kind, and it's such a privilege to actually talk about family planning in Pakistan, where a lot of people are very interested in. We've done a number of things over the decades, but we also find ourselves struggling to actually make it to where we would like to be. I'm going to actually go ahead and start sharing the screen. I have some slides that I'll talk through, and please interrupt and ask. I think we'll just keep it open. We'll definitely leave a lot of time at the end for questions and answers. लेकिन अगर आप लोगों को और सवाल पूछने हैं तो बीच में आप पूछ सकते हैं. So let's get started. Here. So, can you see me, the slides?
Yes.
All right. So, family planning in Pakistan, what are some of the issues? What has been the progress? And where do we go from here? Obviously, family planning is actually a sub-subject of the larger issue of population. Population is much larger. So it includes rights, it includes education of people, health, economy, creation of jobs, getting people opportunities, social fabric of things, social lives of things, of people, particularly youth and of women, particularly women who don't enter workplace very much social. We know that workforce participation in Pakistan is amongst the lowest in the world, some 20% overall, and less than 10% in cities. And of course, issues and health of the elderly. But all of it comes down to a critical point where if your population growth rate is very fast, you will outstrip all kinds of resources you have. You'll always be chasing something that's always in the future. Very good paper on this in 2006 by Durin Ayab at PIDE. You can look it up. It's online. I can share links to it or PDF to it with Michelle if you are interested. But having said that, let's talk about family planning as it affects population. So a little bit of a history. Pakistan is actually a pioneer in the region. We started our very first family planning program in 1954, a combination of public sector and private sector. In '66, it was actually put into the government. It became a government program and was again considered one of its earliest in the region. Since then, we've actually had very slow progress. So contraceptive CPR or contraceptive prevalence rate, the proportion of women in reproductive age, which is married women in Pakistan, 15 to 49 years old, the number of percentage of those that are using any kind of family planning is called contraceptive prevalence rate, or CPR. You can see in blue line, it's languished pretty low at 4 and 3% until well into 80s, increasing ever so slightly to 12% by 90 or 91. A huge jump, largely on the back of the newly formed Lady Health Worker Program in the 90s, going up to about 31% in 33% in 2001, 2002. And since then, it's basically traded sideways. Now, interestingly, fertility rate, which is basically the number of children a woman would have in her lifetime, has actually trended down ever so slowly. Part of it reflects the family planning rates going up in the 90s, but also, as we'll discuss it in a little bit, age of marriage of women has actually shifted upward. And so some of the very early 1 or 2 children have just not been born to another number of women who came to reproductive age after the 90s. So, but then, as you can see, from 90 onward, the progress has been slow, ever so slightly trending down. Any questions and thoughts thus far? Right. So, if not, then the other thing is our rate of population growth is among.
There's a question in the chat by Asra. She's asking, can you talk more about what caused the spike in CPR?
What caused the spike? I think it was the Lady Health Worker Program. It was constituted in 93, fully functional by 94, and we were seeing incredible results by 98. By 98, we said, if it's working very well, let's expand this. We expanded it without expanding the funding for it. So we went from something like 35,000 lady health workers across Pakistan to a little over 100,000 by 2001, but with no additional programming. And we said, since it works so well for family planning, let's have them do other things. And so now by 2007 or 8, they had 22 things they were doing. They were spending about 6% of their time, about 57 minutes on average per week. And their impact on family planning just completely disappeared after at the beginning of the 2000s. So I think that was the main driver of the biggest spike we've seen. A household outreach program, mainly in rural communities. And of course, not to say that Pakistan population growth rate is 2.4%. That's one of the highest in the region, barring Afghanistan. So moving on to who is using family planning. So as said, most of our data is on married women between the ages of 15 and 49. And these are graphs that you see from, in blue one, from 1990 all the way up, or in this case, down to the yellow ones in 2017-18. It shows that women have more and more births as they grow older, of course, but their peak fertility is reached around 25 years, between 25 and 29 years of age. And that statistic has not changed that much. So the number of children may be declining ever so slightly, as you saw in fertility trends. Lekin, that peak age is reached exactly at the same time, 3 decades out. What is interesting is the peak age of family planning use. In 2012, the national survey was coming a decade later, between 35 and 39. But when we've surveyed back 5 years later in 2017, that peak of family planning use had pushed down even further 5 years. So almost as if it was the same cohort of women who were using family planning that started using, that just got pushed out by 5 years. Sorry, somebody was asking a question?
Yes, actually, could you kind of explain why it's shifted further? Like people are using family planning later, even though the CPR has kind of stayed static, but it's worse that it's shifted. So we are one child less, but the use of family planning, starting it, has gone further. Could you kind of explain on that?
Yeah, so no good answers, but I think one of the things is that it's the same group of people that were primarily targeted. Remember, a lot of the targeting was through lady health workers. They keep going to the same households. We know that. They are reluctant to start new households out. There is a lot of reluctance on starting younger couples, particularly couples with less than 2 or 3 children, out on family planning. We hear this again and again across various regions in the country. So that happens. I think as these people grow older, but not quite hitting 49, they continue to be included in surveys in the 15 to 49-year group. They have the prevalence remain the same. New people are not entering, and they're having fewer children because a certain group is just on the other side. Age of marriage is going up. It used to be about 17 in 1991. It's about almost 20, 21 right now, particularly in cities where it's almost 22 and a half. So that is going up. So that one child is not happening between the in teenage years for a lot of women. I think that's probably why you're seeing this particular trend. The point I'm trying to make is that we've had a lot of programming between 2012 and 17. A lot of money was invested both by the government, we'll see that, as well as donors. And we're really not seeing a whole lot of impact. A lot of my talk will actually discuss those issues. Any questions on this? Right. So again, staying with who's using family planning, obviously there's an issue of rising age at marriage. I've talked about that. Women continue to face, couples actually continue to face this huge pressure to have that first child early. Their fertility is questioned. A lot of it has to do perhaps with how we continue to look at marriage as a means to have children and to have as many of them. It's a throwback, I feel, as societies become more modernized and non-agricultural, that it's got to do with norms that probably are not holding very much true in modern societies, but those norms are still to be shared, and that's important. Michelle, there's questions coming up in chat. I can't see them while I have this thing on, so I'll trust that you will be checking that, and if there's a question that I need to answer.
Do you want me to pose all those questions towards the end, or would you like to answer as you go?
Do you feel that there's anything that requires that will clarify some of the issues, or we can deal with them, or we can just go over them at the end, whichever way. I'm okay with either.
So there is a question in the chat by Astra as well. So she's saying that she's not sure if there's been a study on this, but she's wondering what challenges were faced by lady health workers when having these family planning conversations with households. Were there any major differences when it came to rural and urban households?
Not so much of what lady health workers say, because what lady health workers tend to say again and again is really interesting. It really makes no difference where you're asking them. They tell you almost exactly what they are taught. So they're repeating their training, and they're projecting that onto what the households say. Why I'm saying that they're training? Because when we go back to the same households and say, look, what do you think? And they tell us different answers from what we've heard from their lady health worker. So lady health workers have been there. I mean, some of them are in their 50s now. They've been doing this for 30 years. And they're basically very used to saying what they've been taught. We hear very different answers about these things, and I guess we can actually have a different discussion on that at some point. That would actually be interesting, or maybe perhaps in the after the talk in the discussion section, we can have a little bit of more of a discussion of what couples are saying about these things. The important thing that I wanted to highlight is that women, particularly for women, but less so for men as well, information about reproductive health and family planning comes very late. So on the right, you can see this this table. This is from a study that we did in South Punjab. Basically, it's a rural and a peri-urban community. Information, we are asking girls, pre-marital girls, as women well into their marriage and with many children, when are they first hearing about these things, and when are they first experiencing these events? So for puberty and menstruation, the information comes fairly quickly, but after the girl starts having her periods, 3 months, within 3 months. Same thing about menstruation. For marriage, nobody talks to her. Nobody talks about, you know, you're going to get married. It's a different household, different dynamics, different people, how you manage those things, what to expect with marriage. Not just, I'm not talking about sex alone. I mean, just the social aspects of living in a household that you haven't grown up in. Nobody talks to her about that. That information she learns from her peers and sisters. Can I ask if people can put their mics on mute? So that comes a little later. And then childbearing news, as she's starting to have second or third child, she's figuring it out, and it's a slow process. Birthing options is the same. Family planning, it turns out that she actually gets to hear first some 9 years to as many as 20 years in some communities after her marriage. This is well around the third or the fourth child for many of these women in their these communities. So it's coming very late. We find that decisions about family planning often are made in consultation by the husband and the wife. Roughly about 50 to 60% of the couples decide mutually. Another 10 to 20%, the husband alone decides. Slightly fewer than that, the woman says that she decided. But that may well be happening. What is really interesting is for a lot of decisions, particularly the ones that are either made, where decisions were made by the men or combined, the methods that they use are male-driven. Condoms primarily, or if they have had many children, they get to go for a tubal ligation surgery, which completely stops fertility. But when the women decide, the methods are different. They're going for more reversible methods. They're going for methods that they can control, like injections and so on and so forth. So it's really interesting that who's got the agency on the decision very much determines what method gets to be used. It's kind of concerning that even today, several decades into fairly aggressive family planning programs, very few people put their own money where their family planning needs are. So they don't end up buying contraceptives. And how do we know that? We've seen a number of programs where people have gone back 1, 2, 3, 4 years later, and the CPR, the contraceptive prevalence rates, they actually start falling, and within 4 years at max, they are back to baseline. So it's almost as if as long as somebody was out there providing services, they were willing to take it. Once that stopped, they stopped. There's not enough driving of the use of family planning by the couples themselves. And that's really concerning. Any questions do we want to answer right now? I'm going to move to supply side after this. Right.
Do you have any
So,
questions?
I'm sorry?
I was wondering if anybody has any questions. Okay, I don't think.
So this is basically just a nutshell view of what the demand for family planning is, or the views from the user's side. This is getting more into numbers about family planning services in Pakistan. And I bring that up because that's where I mostly work with the government, both the federal government as well as provincial. So contraceptive prevalence rate in Pakistan for the last several years has languished between 30 and 34%. What that means is if you multiply that by the census figures for population, that's 11.4 million users of family planning. About 10% of those use traditional methods. So if you're asking for modern methods, the more safe and effective ones, that's only 25% of married women of reproductive age. That's about 8.3 million users. So there's a drop of about 2 million right there. But then if you look at, because some of the modern methods like tubal ligation, for example, or an intrauterine device which lasts for several years, many of these women have had their method in a year previous to the current one, so more than 12 months ago. If you want to know how many women get served with family planning services each year, that's about 4.9 million, or 15% of married women of reproductive age. That's just it. 5 million women. There are about something like 30 plus million women of reproductive age right now. But only 15% of those are using availing family planning services. That's all the public sector, all the private sector, all the shops, all the chemists, all put together. That number has gone up slightly, but mostly it reflects over the years, but it mostly reflects the increase in population. So this 15% remains the same for the last 10 years. So that this 4.9 million users, where are they getting their services? It turns out that about slightly less than 1 million get these from departments of health at the provincial level. Another 750,000 from the population welfare department. So both combined, public sector about 1.6 million users, 1.7 million users. NGO and private clinics, only about 500,000 people, or 11% of all users. Most of them, about 2.7 million, or 55% of them, buy their own methods, mostly condoms and pills, from a shop or a chemist. And that's a staggering statistic. The problem with that is this self-buying comes with no counseling, no management, side effect, and so on and so forth. Public sector only accounts for 1/3 of all users in Pakistan, or 5% of all married women. To put this into perspective, there are about 18,000 public sector health facilities that can potentially provide family planning services. So, and then about 700,000 are served by lady health workers. So about 800,000 women are served by 16,000 facilities. Just do your maths. It's a small number. It's like 50 per facility per year. So Pakistan came out with this commitment to increase its CPR in 2012, there was this big summit called the London Summit, and we committed at that time to raise our CPR at that time to 2020, and now that's we moved to 25 to 50%. And you ask people, how do you think that's going to happen, since we've actually just stayed between 30 and 35 for the longest time? And it's like, oh, but we can do 2% increase per year or 3% increase per year. And so like, okay, the problem is 3% does not translate into how many people you need to man the services, how many doctors, nurses, or technicians, how many drugs you'll have to buy, and where you place. So what we did was we actually multiplied that those percentages with numbers from census figures for that year. And so it turns out that 50% CPR means 20 million women. That's what we need to do in the next 3 years if we want to reach our national targets of 50%. What that means is we need to add another 9 million women. That's a typo, that's 9 million women additionally. But if you actually just look at the difference between the current service delivery, which is about 5 million, we need to add an additional 15 million women served each year. But that becomes a little bit more complicated. It turns out that we have not seen any increase or any substantial increase in the number of women and that are proportion of women that are buying their own methods. That's kind of maxed out around 2.7 million. Women served by lady health workers has maxed around 750,000 for the last 5 or 10 years. So realistically, the only chance of increasing your footprint is either public sector facilities or private sector facilities. They combine to serve about 1.5 million women. That number needs to go to 15 million or 1,000% increase in the next 3 years if we are to meet our target. And that is a very different conversation than increasing 3% per year. A lot of, there are options to do this. Outreach is definitely a major option. There are others that I'll discuss in just a bit. Any questions thus far? This basically is just a working of the same thing, which says that you can look at it at the provincial level. The numbers are equally high. It's between 830% or 8.5 times increase in KP to as much as 12.5 times or 1,250% increase in Punjab. Across the board, you're looking at very high numbers of change or rate of change that we need to achieve to reach our 50% target. Right, so moving on, what do we know about the family planning services? We've discussed that demand remains stagnant. I mentioned that we find that when programs stop, people stop coming out and getting methods on their own. We know that certain key demographics, such as young couples, but most importantly, urban poor are completely ignored in most programming. Some of that is changing. Young couples are definitely part of programming, but programming generally tends to remain very, very rural, even though 1/3 of Pakistan actually lives in an urban slum, according to not so recent report by World Bank in 2015. Entirely too much emphasis on programs is on doing some activities or training more and more providers again and again and again. We see very little returns for training in programs that are run for multiple years. A lot of times programs come in, they say, oh, international best practice, we'll apply that. Very low acceptance or even understanding of local solutions that can be very, very low cost. So it turns out that family planning in Pakistan remains very expensive. In the government sector, it costs about $50 to $70 or in previous dollar terms, so maybe about 8,000 rupees to reach a couple every year. Similar costs would be somewhere around 1200 to 1500 rupees if you use some of the local programs and learning. But we tend to do a lot of what we are told from other countries. The biggest problem that I've found, we've a paper coming out on this, is that programming is piecemeal, which essentially means that people will come and say, look, हमें एक clinic मिल गई है, हम उसमें जाके नई बड़ी अच्छी सी services कर देते हैं. So what's not happening is कि they're not thinking of population. So एक आपने clinic कर दिया, आपको ये नहीं पता है कि कितने लोग वहाँ पे serve हुए and so on and so forth. वो आपकी उस मोहल्ले को या उस आबादी को कितना सर्व कर रही है आपको पता नहीं है. And it turns out when you do a lot of those, आपको national survey में उसका impact नजर ही नहीं आता है. So piecemeal programming that are built around either shops or clinics is insufficient. आपको communities के बारे में सोचना जरूरी है. What does success look like in Pakistan? And by success, we're talking about programs that have raised किसी measurable जगह पे CPR by at least 4% or more per year. What's been is कि बड़ा supply side program है. उसका मतलब है कि आप you've paid a lot of attention to detail about providers, clinics वगैरह. You absolutely made sure कि supplies, contraceptives की supplies were not interrupted. People get very discouraged अगर उनकी supply रुक जाती है, फिर वो अक्सर वापस नहीं आते. And most importantly, every successful program had outreach to houses. Clients simply are not showing up to clinics and facilities as much as you would like. Uske niche, there's a list of the 5 successful programs that at least I know of that meet that 4% per year criteria. Again, after the programs were stopped, virtually all of those areas saw a decline in CPR. 4 से 5 साल में pretty much close to the baseline. So again, there needs to be some thought about what maintains sustainability. So to start closing the gap, what do we know? Nearly all gains are from social marketing, which is basically shops and pharmacies and chemists. Not much is happening in the clinics, social franchising. A lot of NGOs are branding, but unka uptake bahut kam hai. 11% of all landscape is served by social franchising clinics. Public sector slightly more, but again, not very much more. Not much has happened to change people's demand. I mean, again, it needs to be emphasized again and again. Piecemeal programming, I mentioned here. A lot of programming remains very, very rural. It misses half of the poor in Pakistan that are living in urban slums. They're more accessible. Aapki programming sasti hogi, and yet programs wahan pe hote nahi hai. We tend to be caught in a donor-driven, Africa-centric paradigm jahan pe sari ki sari poverty rural samjhi jati hai. Government ki funding is there. So koi 18 से 20 billion रुपए सालाना पाकिस्तान में फैमिली प्लानिंग में खर्च होते हैं, जिसमें से कोई 15 से 16 बिलियन गवर्नमेंट के होते हैं. मगर virtually all of it pays salaries and fixed costs such as बिजली के पैसे and bills and stuff. Very little of it buys contraceptives, and contraceptives then वो खत्म हो जाते हैं. There are months where clinics don't have any supplies, and फिर why would anybody come, and वो एक दफा नहीं आएंगे तो फिर वो बहुत सालों तक नहीं आते. So you lose credibility. Demand side पे मैंने mention किया, there's a lot of societal pressures. Couples feel pressure to have the first child. They uptake their family planning very passively. कोई आके दे देता है तो ले लेते हैं, they don't themselves. Pressure to have more and more children is there. Pressure to have more boys is there. We have a paper out that shows that actually, even when you're not doing things like the sex selective abortions and female infanticide, जो कि और जगहों पे describe किया है, if you just keep on having children, if your last child is a girl, you'll still have a very lopsided boy to girl ratio, almost 1.1 या like 10 या 11%, even 15-16% ज़्यादा boys हो जाएंगे if you insist on having your last child as a boy. So, and then of course, the social construct which says that औरतों की birth and family is tied to their fertility. So those are things that are driving some of these issues. A little bit on government I'm not going to go into detail. Government can ensure supplies. There's various ways. Funding is definitely a major thing, although not so much. I think government ki funding is very largely underutilized. जो होते हैं वो भी नहीं खर्च कर पाते हैं, और जो करते हैं वो salaries के ऊपर ही करते हैं. There are some regulatory barriers, like important. जैसे India is the cheapest place we can buy contraceptives, and yet हमें इजाजत नहीं है. So हमारे IUCD ब्राजील से आते हैं जो कि 3 गुने ज़्यादा महंगे होते हैं. Again, quality के ऊपर कर सकते हैं. Data का इस्तेमाल बहुत कम है. I'll just show you in just a second a little bit more. Some level of there's some push to actually use. This was a recommendation to the federal government कि वो ICT को ही जो उनके implementation की jurisdiction में उसको model programming district की तरह इस्तेमाल कर सकते हैं to ensure. इस्लामाबाद में generally family planning rates अब पूरे मुल्क से ज़्यादा हैं, लेकिन मज़ीद बेहतर किया जा सकता है. And just to show कि some of the data, so this is a unit that's recently been formed by our team with the government. This team sits at the Ministry of Health in the policy unit. It's called the Data Evaluations for Evidence in Policy Unit. And the team actually, unko population is their top priority. और चीज़ों पे भी ये काम करते हैं. And they are starting to produce from last month evidence जो हम high level पे दे सकें, easy to understand, ताकि ministry की leadership can take some actions on it. वरना यही होता था कि जी आप क्यों नहीं कर रहे हैं, जी हमारे पास data तो आ रहा है लेकिन उसका इस्तेमाल नजर नहीं आ रहा है. This is actually an issue in Journal of Pakistan Medical Association, which just came out a few months ago, जिसमें ये काफी सारे issues हमने कई articles हैं जो publish किए गए. And it's online. I'll send a link to Michelle for distribution. I think that's pretty much it. I'll stop and take questions.
Thank you so much, Dr. Adnan, for that very, very insightful presentation. So I do want to open the floor to everybody. And if you want me to read out your questions, or if you would like to introduce yourselves, you can unmute yourself and ask the question. That would be great, whichever way you feel comfortable. There's a question by Amna Durrani. Amna, go ahead. You can unmute yourself.
Thank you very much, Dr. Adnan and Michelle, for this very insightful presentation. I'm Amna. I work with Khyber Pakhtunkhwa Commission on the Status of Women as Director Program. And I have a question. for Dr. Saab, that do you think, or I'm not quite sure whether you study in your work that aspect also, but is there any evidence that you might have come across where radicalization might have posed challenges in the work of lady health workers, especially because we saw that there was excellent work being done by them in the 90s, but post 2000, I mean 2000, and that was the time of 9/11. It kind of coincides with that time period. But then the wave of radicalization and reaching out to the communities and counseling them or taking this up with them, is there any evidence where it shows that there were co-linkages and linkages and correlation with that respect, where they faced challenges in communicating this to the communities? Thank you.
So anecdotally तो सुनने में आता है कि रोक दिया गया, but generally नहीं. Largely speaking, lady health workers की limitation जो है वो a lot of them are self-driven. वो उन्होंने अपनी internalize, उन्होंने fix कर लिया है कि हमने ये करना है और ये नहीं करना है, and they don't go beyond that. Interestingly, religious motivated resistance नहीं देखी जा रही. Pakistan is one of the leading countries जहाँ पे ना इसके against ना immunization के actually वो होता क्या है कि जब आप decide कर लेते हैं कि हमने नहीं करना है तो फिर आप decide करते हैं. So family planning के अंदर of all people who refuse to use family planning, only 6% say they do it because of religious reasons. So that is not happening. Actually, some data on immunization, हम लोग अभी पोलियो पे भी देख के आ रहे हैं, including KP के अंदर, including FATA के अंदर, हमें बहुत direct link नहीं नजर आता है. What really happens is कि लोग करते हैं तो कर लेते हैं, even when there is religious influences जो उनको negate कर रहे होते हैं, लोग फिर भी कर लेते हैं जब उनको करना होता है. जी नूर आपको.
जी अस्सलाम वालेकुम. So thank you so much, Dr. Adnan. Really, it is a wonderful presentation and very comprehensive. ये बिल्कुल हमारा एक जो है ना ignored और एक I know okay, this is a very important topic to talk about the family planning services in Pakistan. Unfortunately, we are lagging behind to achieve our targets because our population has been increasing day by day, but our family planning services and other remains unchanged or remain same. So I would like to ask, because I worked this is a Noura Sanchachar, I am working as a program policy officer to support scaling up nutrition planning and development department, government of Sindh. So I'm closely working, planning commission as well as other aid sectors, including population welfare department, government of Sindh. So there is a dire need to improve our health, the family planning services. When I conducted my thesis in 2010, so the CPR rate was 34, and after 10 years we are still on same place and same. So there is a mega, and we didn't achieve what is required for the program. As far as the LHWs are concerned, they are they are very they have been conducting multi sectoral engagements. They have been engaged in multi tasks, so that they don't have their priority to continue with family planning services. And my third comment or question is, our majority of our population and the clients are going to receive services at public healthcare center, but unfortunately their service is very poor, and if there is availability, then no one is to give them awareness and other like things. So do you have any strategy or plan to overcome these issues? Thank you. Over to you.
Aisha, you're asking.
Thank you. Are you going to answer Noor Saab's question, or
I
should
think
I ask
Nur
my
Saab had
question?
comments. Nur Saab had comments. So I think those are important points to make. Yes.
Yeah. Okay. So my question is that with demand kind of being static and a younger cohort of Mavra entering every year, so I don't know the exact number of Mavra that enter every year who require family planning. And with our very low rates of family planning in young Mavra, is the CPR, are there concerns that the CPR might actually fall rather than going up, or are secular trends going to kind of make it go up? Matlab, what are your thoughts on demand creation and the younger Mavra that are entering? What are their leanings likely to be?
So the numbers, the proportion certainly hasn't fallen. I mean, it's languished. It was 30%, 35%, 34%. I mean, 2006 में से लेके अब तक it hasn't fallen. Not sure why. You're right. Between 300 and 500,000 women entered this group, 15 to 49 married. So वो उनकी क्या वो हो रही है? I mean, I guess secular trends are there. लोगों का की knowledge generally बेहतर हो रही है. But major drivers seem not to be changing. I mean, the biggest driver of family planning globally, including in developing countries, is women entering workplace. I mean, there's very clear data from the West. There's very clear data from India. This is the number one driver. हमारे पास 9% women in urban areas enter workplace, 21% enter nationally. So वो चीजें नहीं change हो रही हैं. So I'm not sure. It hasn't fallen. I'm kind of optimistic it won't fall further. लेकिन who knows?
Gee, does anybody else have any questions? Gee, so I actually have a question. So I know this is, of course, a very, very pertinent topic, given that we have a population of about 220 million plus, and in the context of Pakistan, of course. So you mentioned that there are certain, on the demand side, there are certain social constructs. So what do you see as, or some very important behavioral interventions that could take place to, break those taboos or constructs in, both rural and urban areas? How do you see that playing out in the future, or some of the steps that we can take to deal with that?
Actually, I think that those would be indirect ones. So the number one thing that will break is things that bring women out into workplace. I mean, Karachi mein Sukh program ka maine zikr kiya. Sukh program had to actually drop एक मोहल्ला, because that was around a factory जिसमें औरतों को टेक्सटाइल पे काम करवाते थे, और वहां पे उनका contraceptive use rate was 67% at the baseline. वो काम कर रही थी. होता ये है कि देखें, पहला बच्चा everybody has them, second भी हो जाता है, तीसरे बच्चे तक you start saying कि look, am I going to take time out for pregnancy and child rearing and stuff, and your desire or whatever the motivations to have children are starting to now go against this other thing कि जी बच्चे भी 2 हो चुके हैं, उनके भी time and demand आ रहे हैं, and then job की certain वो होती. So देखा ये गया है कि women who work tend to have fewer children. इंडिया का जो लेबर फोर्स पार्टिसिपेशन सर्वे है उसमें again and again वो ये बार-बार दिखाते हैं कि ये हो रहा है. हमारे पास भी यही होना होगा कि किसी तरह से, particularly urban area में कोई वजह नहीं है कि औरतें काम ना करें. I mean, वो अलग बात है कि jobs कम है तो मर्द ही prioritize हो जाते हैं jobs पे, लेकिन if job market opens up somehow, I think you'll see a massive push in that direction, and CPR automatically खींचना शुरू हो जाएगा ऊपर की तरफ. I think that's probably your biggest bet.
And in rural areas, for people who are living in joint family systems, so there's obviously like additional pressures that a woman faces, and she might not obviously have the opportunities that an urban woman has. So how would you address those challenges there?
So rural areas में तो बड़ा clear है कि आपको outreach करनी होगी, not necessarily government की लेडी हेल्थ वर्कर outreach, क्योंकि वो बहुत महंगी पड़ रही है, अब 18 से 22,000 रुपए उनकी सैलरी हो गई है। इनफॉर्मली आपको हेल्थ डिपार्टमेंट्स कहते हैं कि हम अफोर्ड ही नहीं कर सकते, दैट्स नॉट गोना हैपन। प्राइवेट सेक्टर में आपको ये करना होगा। आयशा runs a program where they actually use quite a bit cheaper services, more limited time लेकिन options such as those will have to be put forth and tested and scaled up. So definitely rural areas में अगर आप outreach ले जाते हैं, hands वालों ने भी ये किया था, बहुत effective होती है। I mean hands के अभी हमने वो किया, 3 साल में इन्होंने 20-22% change कर लिया in extremely remote districts in Sindh. So yeah, I mean different solutions. Urban में jobs, rural में outreach. I mean, those are the big ones. I mean, obviously, और चीजें भी हो सकती हैं।
All right, thank you. So are there any other questions that anybody would like to ask before we close the session? We've got
जी Samir.
thumbs up from Samir. I don't know if he wants to ask a question or... Okay, I think it was just a thumbs up for the president.
Okay,
Yeah,
thank you.
hi. Thank you, Michelle, and thank you, Dr. Saab. Basically, it's not a question, but it's more of a comment. This is Mohyuddin, by the way. My first name is Samir, so I think that's what's showing on the screen. So basically, while we are focusing on demand generation and outreach, one of my concerns has been the unmet need, which is around 17%. And I feel that perhaps while we are focusing on demand generation, we should equally focus on the unmet need and perhaps, the advocacy related to this kind of an issue. So any comments from you or any thoughts? That would be helpful. Thank you.
See, for everybody, so unmet need is as a calculated term. Unmet need is calculated by asking people कि आपकी current pregnancy या last pregnancy wanted थी या नहीं थी? अगर वो did you want that child either at that time or ever? And उसको फिर उससे आप calculation करते हैं. The problem, Mohyuddin, is कि at least जो पाकिस्तान का data मैंने देखा है, that really never unmet need at a household level. It's I mean, unmet need was always defined at a population level. It's a calculated estimate. Uska household counterpart does not hold up, at least in Pakistan ka data. So if somebody has unmet need for not having a child right there and then, are they using a family planning? And even if you ask them, they don't connect that. And certainly not connecting them to stopping families. And by the way, that's the other thing that we found again and again. Virtually nobody wants to choose a permanent method. So I mean, अगर आप Ecuador में जाएं या South America में मुख्तलिफ जगहों पे जाएं, which are very, very Catholic countries, वहाँ पे average age of tubal ligation is 26. They have 2, 3, 4 children by that time, and then they stop. The women then undergo the operation to stop having children. हमारे पास the same operation happens on average at 39. So I'm not sure if unmet need can actually be translated, at least in Pakistan's context, into programming that directly. I think it's just a program, global, you get a 30,000 feet view indicator that you use to measure national progress.
Thank you. That's helpful.
And are there any other questions?
Thank you, everyone. So it's been a pleasure and a privilege.
Thank you so much, Dr. Adnan, for this and for joining us and for taking out the time to do this. And thank you to everybody for joining as well. And I will let everybody go now and enjoy the rest of their evening. Thank you. Take
Thank
care.
you.
Thank you for a very informative session. Thank you and good night.
Good night.
Hafiz.